Good morning, everyone. Thank you so much all for getting up early this morning and attending this session. My name is Anna Evans Phillips. I'm at the University of Pittsburgh, and I have the honor of chairing the Young Trainees Committee for the American Pancreatic Association this year. I would like to welcome you all to this first ever Young Investigators Abstract session. And so I'd like to congratulate all of the investigators who are presenting this morning. These investigators are early in their careers, but have shown extreme dedication to their work and to forwarding the cause of academic medicine in trainees and junior faculty members. And so this morning, again, I'd like to welcome you all, and I would like to encourage, the young trainees certainly to reach out for any additional guidance that you might see to the, wonderful group of mentors that are present at this meeting. I'm sure more will come in as the session goes along. One additional reminder for you is just that there is a member survey for all of the members of the American Pancreatic Association, and if you haven't yet had a chance to fill it out, I certainly recommend doing so. As a young trainee, we want to hear what it is that we could do better in order to serve your needs and help the APA become something that you feel like you have ownership of as well. And so with that, I'd like to welcome Dr. Lee and Dr. Jagannath for the moderators of the session and our investigators. Thank you so much. Look forward to your talks.
Welcome, everyone. My name is Bomi Lee from Stanford University, and I'll be serving the moderator for this session. And
hi, welcome everyone. My name is Soumya Jagannath Mahapatra. I'm from All India Institute of Medical Sciences, New Delhi.
So for all speakers in this session, you have 7 minutes presentation followed by 3-minute question and answer. Please respect the time. So now we are moving along with this session, and first speaker is Jason Pitaresi, tumor-derived PTHRP governs pancreatic cancer, cachexia, and antibody blockade prevents adipose tissue wasting.
Thank you for the introduction and for inviting me to tell you about this story today. So last year I presented on a similar story regarding the role of PTHRP in driving tumorigenesis and metastasis. And today I'm going to tell you for the first time some unpublished data about its role in driving cancer-associated cachexia. Okay, thank you. I have no conflicts of interest. So this is our paper that came out last year. As I mentioned, PTHRP has potential oncogenic role in pancreatic cancer. And I'm just going to quickly walk you through some of the key points because I use a lot of these tools in my cachexia study as well. So we were able to show that PTHLH, the gene that encodes for PTHRP, is directly adjacent to KRAS. It's about 2 megabases away on both the mouse and human genome. It is often co-amplified, almost exclusively co-amplified with KRAS. And this is important because PTHRP is a squamous lineage gene and is thought to drive some of the squamous or basal-like subtypes of pancreatic cancer. We collaborated with Fayez Noda and got access to the COMPASS trial data, and he was able to show that really this is a great marker for that squamous or basal-like subtype. It marks about 50% of patients by copy number gains and nearly all of them by RNA. I'm a mouse modeler, and using some of our mouse models where we study EMT or epithelial mesenchymal transition, as well as metastasis, every screen or every RNA-seq we run, this gene appears in the top 10 in the highly metastatic cells. This, in our mind, along with some functional and in vitro experiments, convinced us to build a mouse model. So we introduced PTHLH LOXP alleles into the KPC mouse model. I personally use the KPC-Y, so a lineage-labeled mouse model. And we were able to show that even deletion of one allele of PTHLH was sufficient to extend survival in these animals. So these animals live about 3 months longer. And we actually have some animals that are about 450 days old. So really long-term survivors of PTHLH deletion. So it definitely has oncogenic roles. And when you lose it, it's a great way to slow down this disease. Fortunately, there are monoclonal neutralizing antibodies that we were able to use where we could inhibit and really neutralize PTHRP. We did this in many different settings. I'm just highlighting a few here. So this is an orthotopic experiment in immunocompetent animals. When we inhibit PTHRP, we can reduce primary tumor burden as well as metastatic outgrowth. So as I mentioned today, I'm going to talk to you about cachexia, and the reason for this is PTHRP has kind of become quite famous in the last couple of years due to some papers from Bruce Spiegelman's group, where he showed that this is a novel cachectokine, where it can induce cancer cachexia in other models of cancer. What does this look like in PDAC? Well, in our KPCY animals, if you compare them to a non-tumor bearing animal, this is a normal white adipose tissue depot on the left. And I think you can appreciate in the KPC tumor bearing animals that these animals are extremely cachectic. And I'm showing kind of two flavors of cachexia. One where you get an adipose tissue browning, which would be the middle one, and you get some loss of overall mass, and then an extreme cachexia on the right where you get a really potent browning and loss of nearly all of the adipose tissue. And the idea is that if we treat with monoclonal neutralizing antibodies, that we can, quote, normalize the adipose tissue, or we can block the cachexia. So here is animals that are non-tumor bearing, treated with anti-IgG or anti-PTHRP. And as you can see, the tumor bearing animals, they reduce their adipose tissue weight, and anti-PTHRP therapy can block this. This is true in multiple white adipose tissue depots that are the WAT. It's also to some extent true in the brown adipose tissue or BAT, as well as muscle such as the gastroc shown here. Now, we think most of our phenotypes are showing up in the adipose tissue because the receptor is expressed on adipocytes, but it is not expressed on muscle cells. But there might be confounder effects. As you lose your adipose tissue, you also lose the muscle mass because of that. And finally, we think that PTHRP is driving this by engaging the receptor on adipocytes and turning on a so-called thermogenic gene program. This ultimately culminates in activation of a gene called UCP1, which is involved in heat generation and ATP production. And it is the reason that your adipose tissue turns brown. So what does this look like in our pancreatic cancer mouse models? So here I'm showing you first the genetically engineered mouse model we made, where we deleted PTHLH, again, one copy in the context of KPCY tumors. And you can see that we begin to normalize the white adipose tissue depots. This is what it looks like at both the gross level as well as the histology. If we were to stain these, the tumors on the left, which are PTHRP competent, would be highly expressing UCP1 and be very brown, whereas the PTHRP deleted animals are, again, starting to look more normalized and now look like white adipose tissue, but importantly have regained most of their mass. This holds true again in multiple white adipose tissue depots, as well as with anti-PTHRP therapy. So these are in large established tumors. We are able to reverse the cachectic burden by treating with anti-PTHRP, again, in a genetically engineered model. Now that in our mind established that PTHLH is necessary for cachexia, but we really wanted to show that it was sufficient as well. So we returned back to our panel of KPCY cell lines. We have probably close to 50 of them. And again, these are all from pure black 6 hosts that we can inject back into immunocompetent animals. And we asked what were the levels of PTHLH expression across all these cell lines, and we chose the one with the lowest PTHLH expression. When we injected that orthotopically back into animals on the left, you can see that it did not cause cachexia despite having a very large tumor. This was a 2-gram tumor. And when we overexpress PTHLH in this cell line, we can now induce cachexia. So PTHLH alone seems to be sufficient to induce cachexia. Obviously, these animals die quite rapidly. They have more cachectic burden, larger primary tumors, as well as more metastases. And that's an important confounding factor. So the field for a long time was kind of thinking that the larger your primary tumor or the more metastases you have, the more cachectic burden you can have. But really, this has been started to be disproved by others in the field, as well as some data that I'm going to show you from myself. So this is a study from Teresa Zimmer's where she deleted IL-6 in KPC cell lines and then did orthotopic implantation. And again, her primary tumors were smaller, but across, in her case, the muscle was really where she saw the cachectic burden for IL-6. She showed that there was no correlation between overall tumor mass and cachectic burden. We have since shown this again in our PTHLH deletion animals. So to remind you, we delete them, the tumors are smaller, and there is no correlation between loss of adiposity or loss of or browning of adipose tissue with relation to tumor size. So we do really think this is a directed mechanism through PTHRP engaging the receptor on adipocytes, and we're now introducing LOX-P alleles into some of the KPCY animals to show that we can block cachexia in the adipocytes. So in summary, PTHRP is really more than hypercalcemia. At last year's meeting, I showed you its roles in tumor growth and metastasis. Today, I told you about cancer cachexia, but we also have some really exciting immunomodulatory functions. So it's involved in MDSC recruitment into the microenvironment, and others have shown its role in dormancy and angiogenesis at the metastatic site. Just really quickly, my last slide, I'd like to really thank my mentors. So last year when I presented this, I was a member of Anil Rusky and Ben Stanger's lab when they were at Penn and now Anil at Columbia. But for the last 2 months, I've been running my own lab at UMass Medical School, and we are actively recruiting. So if there are any graduate students looking to do a postdoc and you are interested in cachexia, we'd love to have you join us.
Thank you, Jason. Congrats. And any question for this talk?
Sorry. Thank you for a really nice talk.
Hey,
Minoti
Jason.
Apte from Sydney. You mentioned that the PTHRP works, or at least has a role in angiogenesis, I think, did you say? Have you looked at stellate cells at all? And
We have looked at stellate cells. So stellate cells are interesting. Stellate cells and fibroblasts both express both PTHRP and the receptor. And in some of our models, when we delete PTHRP, we do see a modest reduction in fibroblasts, the SMA positive fraction, so activated fibroblasts, I guess. I can't really speak to the stellate cells, the resident cells. We haven't looked at that yet.
Rolf Brecken, UT Southwestern. Jason, is there do serum levels of PTHRP correlate with cachexia or tumor burden or other measures?
Yeah, we've tried to use some of these ELISA-based assays, and when I present this work to the PTHRP community, because there's a large community studying this, they all say that those ELISA assays are quite flawed because really the mature final peptide is very tiny, and it's been impossible to really get a sandwich ELISA to work properly. So the short answer is we're never able to detect it in the serum unless it's at very, very high levels where you're not getting that cleavage product, you're getting the more full-length version. So we've looked but haven't been able to find it. We're currently working with some of the I would say world experts in PTHRP to try to build some new microfluidic devices to maybe measure these things more accurately.
So a related question, does the monoclonal antibody that you're using to inhibit recognize the functional
Yes,
peptide or is it okay?
absolutely. Yeah. So it recognized the mature fragment that binds to the PTH1 receptor, which is what we think is modulating this cachectic phenotype.
Sorry, actually, we have to move on to the next speaker. So maybe you can have some time after this session. So our next speaker is Soumya Majumdar, tissue DNA methylation profile of synchronous and metachronous pancreatic ductal adenocarcinoma.
Good morning, everyone. On behalf of my team at Mayo Clinic, I would like to thank the APA Young Investigator Abstract Committee for the opportunity to present our work here. Here are my disclosures. So let's take a look at the pancreas cancer problem. Compared to a lot of other cancers, pancreas cancer is not very common. However, it is a lethal disease, and it is currently the third leading cause of cancer-related death in the United States. More than 50% of patients with pancreatic cancer are diagnosed at an advanced metastatic stage. And the overall 5-year survival is 11%. In these nearly 50% patients, that number drops to 3%. And in the small subset of about 12% patients who present with localized disease, that survival is 44%. In that subset that's amenable to surgical resection, it has been established that a negative surgical margin and major pathologic response in the tumor, in the resected tumor, is associated with increased recurrence-free survival. However, the presence of synchronous lymphadenopathy is associated with the worst recurrence-free survival. Moreover, metachronous recurrence after treatment is not infrequent, and several series demonstrate that 30 to 40% of patients after a potentially curative resection develop metachronous recurrence of pancreatic cancer. So a key question is, how do we stop this progression? and better select patients for surgery and improve postoperative survival. Currently, there are no reliable biomarkers for detection of either synchronous lymph node disease prior to resection or metachronous metastasis after pancreatic cancer surgery. So what do we know about methylated DNA markers for pancreatic ductal adenocarcinoma? We started with a tissue discovery experiment several years back, looking at identifying using RRBS areas that are differentially methylated between cancer and normal pancreatic tissue. We have then taken this through multiple steps of tissue validation independent samples and subsequently and more recently plasma testing, where we demonstrated that a panel of 13 methylated DNA markers listed here demonstrate high sensitivity and specificity for the diagnosis of treatment-naive pancreatic ductal adenocarcinoma. However, the distribution of these methylated DNA markers in tissue, specifically in synchronous lymph nodes and metachronous recurrence of PDAC, has not been previously studied. So here we decided to take a step back and go back to tissue studies using the set of markers that we already established assays in plasma. And we wanted to answer three very specific questions. We want to compare the tissue methylation profile of lymph node negative primary PDAC with lymph node positive disease, synchronous PDAC lymph node metastasis versus benign lymph nodes, both in the field of ductal adenocarcinoma as well as neuroendocrine tumors, and a paired analysis of metachronous PDAC deposits versus paired primary tissue from the same patient. So we identified FFPE tissue samples from our institutional biorepository. We had the histology reviewed by an expert pancreas pathologist and abstracted the clinical data. And then the tissue samples were randomized and blinded for the lab team. We performed QMSP from bisulfite converted DNA, and the methylation marker levels were normalized to beta-actin. We then derived two composite scores using principal component analysis, one for pancreatic tissue, the other for lymph nodes, which I'll refer to as PC pancreas and PC lymph node in subsequent slides. And the first principal component of this score was compared between our groups of interest. For primary PDAC, we had 110 unique tissue samples, of which 40 were with positive lymph nodes, 70 without a positive lymph node, and 25 paired primary and metachronous deposits. For lymph node tissue, we had 115 samples, and there we had 35 that were benign lymph nodes in the field of neuroendocrine tumor, 40 that were benign but were in the field of ductal adenocarcinoma, and 40 that had synchronous involvement in the field of PDAC. When we looked at comparing the node positive and the node negative PDAC, the PC1 pancreas score was significantly higher in the node positive cases. Here's a heat map looking at the distribution of each individual marker represented on rows at 95% specificity. And as you can see, for both the benign lymph nodes in the field of neuroendocrine tumor and in the field of ductal adenocarcinoma, there was weak to no signal. However, that was very different in the synchronous lymph nodes that were markedly positive. When we compared this across the three lymph node groups, you can see that the PC1 lymph node was significantly higher in synchronous lymphadenopathy, and there was no signal in the benign lymph nodes, even if they were in the field of ductal adenocarcinoma. Comparing paired metachronous and primary tumor, we again demonstrated that metachronous PDAC recurrence had a stronger signal compared to the primary tumor itself. So in summary, we can conclude that the tissue methylated DNA marker levels are elevated in pancreatic tissue in node positive PDAC compared to node negative PDAC. They are higher in metachronous PDAC deposits compared to paired primary PDAC from the same patient, and are able to discriminate synchronous malignant lymphadenopathy from benign lymph nodes in the field of ductal adenocarcinoma. These results provide scientific rationale for exploring this panel in plasma on adaptive clinical trial platforms that would help us better select patients for surgery and optimize postoperative surveillance. This work would not have been possible for this tremendous team of individuals who I have the pleasure of working together with at Mayo Clinic, Special shout out to Rondell Graham, who was the study pathologist, and Karen Dwaring, who leads the program management for our program. She's in the audience today. And I'm grateful for the opportunity to co-lead this program with Gloria Peterson, and would like to acknowledge our funding sources. Thank you for your attention, and I would be happy to take questions.
Any question for this talk?
Somnath, University of Miami. Great talk. I was wondering, in the markers that you were utilizing to study, yes, were you specifically talking about the promoter methylation, or were you, like any other places, were you also interested in your RRBS studies?
No, the differentially methylated regions are in the promoter region of the gene.
I mean, people often talk about, sometimes the shows and the boundaries being interested as well. So I was just wondering, in your experience, if you came across those reasons,
So when we did our tissue discovery experiments and used the sequential filtering criteria, these were the regions that kind of passed through all of those sequential steps that included high fold change and contiguous methylation in that region.
Thank you.
Yeah.
Any more questions? Then we can move on to next talk.
Thank you.
Thank you. So our next speaker is Chamini Pereira, proteomic profiling of co-cultured pancreatic cancer and stellate cells and their extracellular vesicle cargo, identification of unique proteins that drive pancreatic cancer progression.
Okay, good morning, everyone. Thank you for this opportunity to present some of our work on proteomics of co-cultured pancreatic cancer and stellate cells and the exosomes. So we know that pancreatic stellate cells, or PSCs, are resident cells of the pancreas. They are also present around early cancer lesions known as pancreatic intraepithelial neoplasms, or PANNs. This is a pancreas section from a KC mouse showing the brown staining for the PSC activation marker alpha smooth muscle actin around PANNs. Once activated, PSCs can secrete collagenous stroma and also interact with cancer cells and drive cancer progression. These interactions may be mediated by factors carried by exosomes. Exosomes are small extracellular vesicles secreted by almost all the cell types. They are typically 40 to 160 nanometer in size with the cup-shaped morphology as shown in this image. Exosomes carry the cellular cargo, which includes proteins, RNAs, and DNA that may mediate cellular communication. Pancreatic cancer cell-derived exosome factors such as certain microRNAs and proteins have been implicated as potential biomarkers. However, very limited studies have been reported on exosomes derived from PSCs cultured either alone or with cancer cells. Therefore, we hypothesize that co-culture of human pancreatic cancer cells and PSCs results in the expression of unique proteins in cell lysates and the exosomes that drive cancer progression. Thus, we aim to perform a comprehensive proteomic profiling of pancreatic cancer and stellate cells and the exosome cargo. To achieve this, we used human pancreatic cancer cell line ASPC1, normal human PSCs, and cancer-associated human PSCs. They were either cultured alone or with ASPC1 cells. After 72 hours of cell culture, we isolated exosomes from cell secretions using ultracentrifugation, and the cell lysates were also collected. Isolated exosomes were characterized for their morphology, size, and purity. Then the proteomic profiling of exosomes and cell lysates were determined using mass spectrometry, followed by gene set enrichment analysis to identify specific pathways. Coming to the results, this representative image shows that the typical cup-shaped morphology and the correct size range of our exosomes, which was also confirmed using the zeta size. Our exosomes were positive for their specific exosome markers such as ALIX and TSG101. And most importantly, they were negative for the non-exosomal marker calnexin. Coming to the proteomic profiling of the cell lysate, this heat map summarizes the proteins that were significantly differentially expressed between the 5 groups. We can see there are 2 clusters, and the underexpression is denoted in light blue and overexpression is in orange. So in the cluster 1, we can see that the proteins in ASPC1 are underexpressed in cluster 2. The pathways related to those clusters are listed here. And in the cluster 2, the proteins related to ASPC1 are overexpressed. Interestingly, in both clusters, cluster 1 and 2, the co-cultured cell lysates, the protein expression approached that of ASPC1. Regarding the exosome proteome profile, this heat map here again summarizes the differential expression between the 5 groups. Underexpression is denoted in light blue and overexpression is in orange. We can see 2 prominent clusters here also, cluster 1 and cluster 2. And some of the pathways are listed in the slide, mediated by those proteins. In the cluster 1, ASPC1 shows protein overexpressed related to the pathways such as telomere organization and cell cycle. But in the cluster 2, ASPC1 derived exosomes show underexpression of proteins. And the cluster 1 can be divided into 2 subclusters, like subcluster A and subcluster B. Interestingly, the subcluster B, which I am going to show here, the co-culture derived exosomes, the protein expression pattern has approached that of ASPC1 cells. But in the subcluster A, in the cluster 1 and the cluster 2, the protein expression pattern of the co-culture derived exosomes approached that of stellate cells. Interestingly, cluster 2 proteins are known to mediate stellate cell specific pathways, such as collagen interactions and ECM degradation, etc. And so our findings suggest that the exosome content in the co-culture settings is largely influenced by the stellate cells. We identified 415 proteins unique to cancer-associated PSC and ASPC1 co-culture cell lysates, and pathway analysis revealed that there are signaling pathways related to pancreatic cancer and insulin signaling mediated by these proteins. The factors in mediating insulin signaling may be relevant to diabetes seen in pancreatic cancer. The functional pathways which are mediated by these unique proteins, as listed here, all of them are known to be involved in cancer biology. We also identified 3 specific proteins of interest apart from those proteins that were previously mentioned, because we performed another analysis using TCGA dataset, and we found that 2 of the 3 proteins were significantly high in cancer patients compared to normal tissue. There were 179 tumor tissue and 171 normal tissue. You can see here that PA15, which is a proliferative and anti-apoptotic, and BAG4, anti-apoptotic and chemoresistance, were significantly high in the cancer tissue compared to the normal tissue. But KCMF1, which is also proliferative, did not show any difference. However, it was the high expression of KCMF1 in the cancer tissue was shown to be related to poor survival in cancer patients. We also identified 101 unique proteins in the co-culture derived exosomes. Of these, 22 proteins were related to complement and coagulation cascade. Some of the factors are listed here, such as factor 9, factor 11, and fibrinogen gamma chain. Of the remaining 79 proteins, we did not identify any specific pathways of interactions, but there were individual proteins such as finger protein, agrine, fibrillin, and silin. They are known to be a part of carcinogenesis and cancer progression. So in conclusion, co-cultured ASPC1 and cancer-associated PSCs produce unique proteins and exosome cargo that are involved in pathways known to potentiate cancer progressions. Our findings imply that 22 unique proteins in cancer-associated PSC and ASPC1-derived exosomes may be associated with pro-inflammatory and hypercoagulability status of pancreatic cancer. Also, characterization of the factors identified in the cellular proteome or exosome cargo may lead to identification of novel biomarkers and therapeutic targets of pancreatic cancer. With that, I would like to thank my supervisor, Professor Minoti Apte, and all the members of the Pancreatic Research Group and our collaborators and funding bodies. Thank you.
Congratulations. Any question for this talk?
So this is Manishan from University of Nebraska Medical Center. My question is, you compared the exosomes in the co-culture and you mentioned that you use the cancer-derived fibroblasts, considering now the heterogeneity. And so can you comment on what stage of cancers those stellate cells are derived from? And do you have any concerns about the heterogeneity in that cargo that you'll get thereof?
So these were patient-derived samples which we got from resected pancreas tissue. Then we isolated cells using the outgrowth method, and they were, of course, undergone a couple of passages. And definitely there is a heterogeneity because these are from 3 different patients with 3 different.
Another question is, you validated your exosome cargoes with the tissue samples. Did you also try to look for some of the markers that were defined in David Leiden's cell paper that you see it in the circulating exosome? Did you see any overlap of any of the biomarkers that you, or the protein cargo that you saw there?
We haven't done that yet, actually.
Thank you.
Thank you.
Thank you for your impressive presentation. There is a question from Heidelberg University. May I ask firstly, since you are using the co-culture systems, how could you identify that your isosome is from which cells? Because you're using the cell lysate.
Yeah, that's a very good question because we have cultured them separately as well. So we actually looked at whether the individual cells are expressing their specific markers, and also whether the co-cultures are coming from which one. It's difficult to differentiate, but they are from both, I believe.
Another simple question is that what's the method that you characterize your stellar cells? How do you know that they are stellar cells derived from the pancreatic cancer patient's tissue?
Yeah, we use immunostaining for alpha SMA and GFAP.
Okay, thank you very much.
So,
Thank you.
So we would like to move to the next speaker, who is Sailendra Gautam. He would be speaking about endothelin axis antagonism improves the efficacy of combination chemotherapy in pancreatic ductal adenocarcinoma.
Good morning, everyone, and thank you, APA, for the opportunity. So today I will be talking how endothelin axis antagonism can enhance tumor perfusion and efficacy of chemotherapies. So this is the outline of my presentation. I will skip this introductory slide Dr. Majumdar already explained today. But there are challenges at every step of pancreatic cancer management, right from the diagnosis to therapy. And today's talk is on drug delivery. So I will be talking on more tumor microenvironment factor that are targeting these tumor microenvironment factors. We can enhance perfusion and drug delivery. So what are these factors? There is a extensive crosstalk between cancer cells and tumor microenvironment, other cells, which enhances extensive stroma in the tumor and disrupt the vascular transport. And our group is working in one of the aspect targeting tumor microenvironment by endothelin axis, which contributes various aspects of cancer stemness, metastasis, angiogenesis, and pain-related things. And what earlier data in our lab we generated, we found that endothelin axis is highly upregulated in human PDAC. And then when we saw at cellular level, we found that epithelial cells, endothelial cells, cancer-associated fibroblasts, and macrophages, they all express this endothelin axis components. And we also found similar data in murine PDAC, the tissues we derived from KPC tumor. And a set of KPC mice we treated with bosentan, which is a dual antagonist of endothelin axis. And we found that several fibrosis-associated markers were reduced in this data. On this data, we made our hypothesis that targeting endothelin axis can deplete the stroma and can enhance the systemic chemotherapy. But the challenge is recapitulating this PDAC in experimental murine models. So we worked on 2 different models here. One was co-implantation model in anthemic nude mice, where we used cancer-associated fibroblasts and pancreatic cancer cell line. We mixed them and implanted in the pancreas. And another is KPC homograph model, where we used tumor-derived chunk and implanted in C57 wild-type mice. And we raised 2 specific questions here, whether ET axis antagonism can enhance the tumor perfusion, and the second question, whether targeting this endothelin axis can enhance the efficacy of chemotherapy. So we recently published a paper in Cancer Letters, and first question we addressed in that, where we showed that we performed perfusion MRI data, where we implanted this cancer cell fibroblast admix in the animal and treated for 7 days these mice with the bosentan and went for perfusion MRI. You can see the data here that bosentan specifically enhanced the uptake of contrast agent gadolinium, which we can consider as a surrogate for a small molecule chemotherapy such as gemcitabine. And you can see that there is no significant difference in the muscle, which is a non-specific tissue. And then we also post MRI, we performed FITC-dextran perfusion assay in these mice, taking high molecular weight FITC-dextran, which is a surrogate for high molecular weight chemotherapy such as Abraxane or nab-paclitaxel. And you can see here that perfusion of this FITC-dextran was significantly high in bosentan treated mice. And we further measured the maximum permeated distance of this FITC-dextran, and you can see here the bosentan enhanced this perfusion distance in these treated mice. We also analyzed those tissues for stroma, particularly the collagen, and you can see here the collagen was significantly reduced. So we concluded here that bosentan enhanced tumor perfusion, and the effect was tumor specific, and stroma specifically reduced after bosentan treatment. But what is the effect of bosentan in PDAC chemotherapy? We took gemcitabine and nab-paclitaxel as a chemotherapy, and this is a strategy for the treatment. And the data in co-implantation model we got here, you can see the bosentan in combination with gemcitabine and Abraxane decreased the tumor burden significantly. We also did luminescence imaging and analyzed histology of those tumors. You can see the tumor in combination treatment were highly necrotic. We moved on to the second model, which is like immunologically relevant model. And what we did, we took chunks and implanted in 20 animals, and we derived the tumor from a 24-week KPC mouse. And we got very similar data like co-implantation model here. Combination 3P therapy decreased the tumor burden significantly. You can see tumor and as well as H&E of those tumors where combination treatment. You can see the immune infiltration as well as the necrosis in combination treatment group here. We further analyzed these tumors for proliferation, and we did Ki67 staining and cleaved Caspase-3 staining, which supports our data showing that combination treatment significantly reduced the tumor burden. More importantly, we analyze liver metastasis in these animals because this is the most common metastasis in PDAC. And you can see this first 3 animals in control groups, you can see all showing metastasis. So this model is good for analyzing metastasis also. And in our treatment groups, when you compare, including bosentan chemotherapy, they reduce the metastatic burden, and the combination treatment specifically, we got significant reduction in metastasis, which you can see here more clearly. So if we summarize the slide, endothelin axis expressed in different components of pancreatic tumor microenvironment, and bosentan enhances tumor perfusion. And animal models obviously are very important to study what kind of therapy you are analyzing, and ET axis antagonism improves this chemotherapy. These are our future direction. We are working on this future to analyze immunological components here and other pathways involved in this to get mechanistic study. And my acknowledgement to my mentor, Dr. Manish Jain and Dr. Batra, who is sitting in the audience here. I showed people who worked on this project specifically. And our collaborators from City of Hope, where our clinical trial is going on targeting this endothelin axis, we are using bosentan in that clinical trial. Thank you so much. Any questions?
Any questions for this talk, please?
Hi.
Hello.
Hi. I have a question about the bosentan. If you can expand a little bit more. So bosentan is a specific 8ET inhibitor. They block both
Yeah.
receptors or
Okay.
just one of them?
Yeah.
Thank you.
So I'm sorry, I forgot to tell you, the bosentan is a dual antagonist and it targets both endothelin A and B receptors. So yeah.
Hi, so.
Hi.
Hi, how are you? I was just looking at very interesting data and thanks for the presentation. So intuitively, when you increase tumor perfusion, you might think that you might facilitate metastasis because you're making it easier for the cells to move out of the primary tumor. So I was wondering whether bosentan also has an effect on decreasing the migratory capacity of tumor cells themselves.
Yeah, so we also had the same doubt, but what happened when we treated these animals? So there are two specific mechanisms we could find from here, that the stroma depletion is one factor, and then second factor is modulating the vasculature, where drug delivery was enhanced. But in case of metastasis, in the last section of the talk, we just specifically focused whether bosentan treated animals, they show any symptom of metastasis, but this was significantly low as compared to the control. So the bosentan treatment, we didn't see any kind of increase in metastasis, particularly in liver, what we analyzed. Yeah, so in vitro assays we are doing in lab to confirm all this. Yeah, thank you so much.
Thank you, Dr. Shailendra. The next talk is on next talk is by Chinenep Daik, which will be talking about acute pancreatitis is associated with gut dysbiosis in children. Dr. Daik, please.
Thank you. I want to thank on behalf of all the authors of this abstract, I want to thank the organizers of this session for inviting me to present our study. And so we'll shift gear a little bit from pancreatic cancer to acute pancreatitis in children, because it's also very important. So we now see acute pancreatitis more in children. And we know that children have an aggressive disease and can progress to chronic pancreatitis within 2 to 4 years of their first AP attack. And it constitutes a huge financial burden to the health system. The severity of the first attack is a risk factor for rapid progression, and management is still largely supportive. In 2017, the NASPIG and Pancreas Committee classified acute pancreatitis in children into mild, moderately severe, and severe episodes of pancreatitis to help define clinical outcomes and also help stratify risk. They included the pediatric SIRS and sepsis criteria into this classification. So previous studies in pediatric acute pancreatitis are largely single-centered and retrospective. So it's very difficult to predict which acute pancreatitis patients will progress to severe AP and those who would progress to acute recurrent attacks, besides those who have genetic mutations. And that is why this acute pancreatitis registry was designed at Cincinnati Children's Hospital, to be able to enroll children with their first episode of pancreatitis, but also follow them longitudinally, collect biomarkers, clinical outcomes, and also patient-reported outcomes. Dr. Nas presented a poster on the patient-reported outcomes yesterday. Please watch out for the publication soon in JPGN. We now know that the pancreas is not a sterile organ. And also what happens in the gut regulates what happens in the pancreas, and in a bidirectional relationship. So short-chain fatty acids released by the gut microbiome can influence antimicrobial peptide production within the pancreas that will help decrease inflammation within the pancreas. Also, when antimicrobial peptide production in the pancreas is low, you can have bacterial overgrowth in the intestine and colonic inflammation. Gut dysbiosis is present in adult pancreatitis and has been linked to both severity and inflammation. But we don't know what happens in children. We don't know if AP is associated with gut microbial dysbiosis in children, and if AP severity is associated with dysbiosis in children. And so we came up with these hypotheses and objectives. The first objective was to characterize the stool microbial taxonomic and functional profile, compare them between children with their first AP attack and healthy controls. We hypothesized that gut dysbiosis impacts children with AP compared to healthy controls. And the second objective was to determine if AP severity affects the stool microbial taxonomic and functional profiles. And we hypothesized that gut dysbiosis is associated with a severe AP course in children. So this is an IRB-approved observational prospective cohort study. On the left, you have the AP cohort, 30 of them, less than 21 years with their first episode of acute pancreatitis, hospitalized at Cincinnati Children's Hospital. Fecal sample was collected within 1 week of AP symptoms. They were compared with a historical control recruited from the GI clinic who had no organic or systemic disease and no IBS symptoms. And so stool sample was collected with that 58 easy sampler kit. DNA extraction was done, the same method of extraction and sequence library production and shotgun genomics, metagenomics between the AP and healthy controls. And then bioinformatic processing and analysis, taxonomic taxonomic and functional profiles was done using the biobakery tree with default parameters. And then the alpha diversity was estimated with the Shannon index via linear regression model, the beta diversity via principal component analysis and PEMANOVA, and then species and pathway abundance via a centered log ratio regression model. This table of the demographic and clinical characteristics shows similar demographic and clinical characteristics between the AP cohort and the healthy control cohort. So this is, we conducted a hierarchical heat map clustering to show the species relative abundance in the AP cohort when compared to the healthy control cohort after a centered log ratio transformation, with the AP cohort represented in light blue to your right, and then the healthy control in the orange to your left. And the light blue showing species that are underexpressed, all the way to the red showing species that are overexpressed. You can see that the species are more abundant in the healthy control cohort when compared to the AP cohort. Similarly, the Shannon index that estimates alpha diversity shows that the healthy control group is more diverse than the AP group. Box plus with interquartile range and median in the middle shows a clear distinction, clear diversity is more in the healthy control group when compared to the AP cohort. Also, the beta diversity estimated with the principal component analysis shows distinct clustering between the AP group represented in blue when compared to the healthy control cohort. We also saw the same significant findings in the mild AP group when compared to the severe AP group, with mild AP represented in red dots and moderately and the severe AP group in the blue dots. There is distinct clustering of species between both cohorts. So this shows the species differential abundance between the mild AP group when compared to the severe AP group. To the left, you see both species that are underexpressed to the left of 0 and overexpressed to the right of 0 in the severe AP group when compared to the mild AP group. When you now zoom in on those species that are overexpressed in the severe AP group, Enterococcus faecalis and Clostridium citronae stand out. In conclusion, our study is the first study that investigates acute pancreatitis and gut dysbiosis in children. And pediatric AP is clearly associated with dysbiosis, just like the adult studies have shown. Especially Enterococcus faecalis may be a marker of severity. And manipulation of the gut microbiome, maybe within the first 24 to 48 hours of attack, may help to decrease the severity of attack, but also may help to decrease the occurrence or recurrence of AP, but yet more to be studied on that. With this, I would like to thank all the members of the Pancreas Care Center at Cincinnati Children's Hospital for all their work, all their efforts towards this work, and also the NIH for funding Dr. Boyle-Heijer. And I also want to particularly thank Dr. Boyle-Heijer for her excellent mentorship and support, and for all her work and efforts towards the mentorship of junior faculty and trainees. Thank you.
Questions for this session, please.
Good Gorlick, New Haven. It's a very nice work and look forward to seeing how that's going to come out with future studies. I remember a study out of Penn that showed how rapidly the microbiome changed between the fasting and fed states and the type of nutrients people were eating. And I wondered if you had controlled in any way for whether the collections were done in fed or fasting states and comparing your pancreatitis patients to control in the mild to the severe.
No, thank you. So I want to repeat your question to make sure I understood it. So you're wondering if we controlled what nutrient or diet those who had the pancreatitis were eating that could have affected their microbiome. Is that your question?
Yes, that's just about it. Whether they were eating or not eating, and if the severe and the mild were, if they were eating the same things.
That's an excellent question. We didn't control for that, but most patients with pancreatitis, we would, start them on a clear liquid diet and advance them as tolerated. It's very likely that those in the mild pancreatitis group were eating more than the severe episode, but we haven't looked at that, so we can look into that. Thank you for that question.
Thank you. We have exceeded the time for this talk. So, hello. So we would like to move to the next speaker, please. So the next speaker is the next speaker is Soumya who would be talking about role of ApoB3C3A in pancreatitis and inflammation-triggered carcinogenesis.
I want to thank the organizers for giving me the opportunity to present our data on the role of ApoB3A in pancreatitis and inflammation-triggered carcinogenesis. So ApoB3A belongs to the ApoB family of enzymes, which is a group of 11 cytidine deaminases. They all share catalytic active deaminase domain, and depending on the enzyme and isoform, they catalyze the deamination from a cytidine to uridine on specific sequence motifs on the RNA and or DNA. A3A is overexpressed during inflammation and in solid tumors, and most recently, large-scale sequencing studies have identified ApoBx as important mutagenic driver in many solid tumor types, including in pancreatic cancer. Looking deeper for ApoB3A in pancreatic tissue samples, we found that A3A is expressed in the epithelial and stroma compartment in specimens of chronic pancreatitis and pancreatic cancer, but it's almost not expressed in normal tissues. In addition, we found that A3A is correlated with a reduced overall survival and with ApoB mutagenesis in pancreatic cancer. But most importantly, we were able to identify a so far unrecognized role for deaminase-independent function of A3A in DNA damage. So we found that ApoB3A, if it's mutated and has no deaminase function, as well as wild-type A3A, needs to increase DNA damage. We also saw more chromosomal instability, and this was featured by Zika sting-mediated metastatic phenotype. In addition, we found that A3A is associated with an interferon gamma-related immune response in pancreatic cancer in mice and in human. And we also found that A3A is associated with an increase of inflammatory pathways when it's highly expressed in pancreatic cancer. So these data let us hypothesize that A3A might also play an important role in the inflammatory disease of the pancreas in acute and in chronic pancreatitis, and might be a potential target to reduce the clinical burden in acute pancreatitis or to minimize the risk of developing pancreatic cancer and chronic pancreatitis. This was our motivation, and we generated, to investigate that, we had generated a novel conditional transgenic mouse model expressing human functional ApoBAC3A. And in order to dissect the role of deaminase deficient in the deaminase competent function of ApoBAC3A, we also generated a mouse model expressing the deaminase deficient form of ApoBAC3A carrying the E72A mutation. And here you can see the deaminase assay showing the deaminase function in the wild type mice, and there's no deaminase function in the mutant mice. Using our cerulean-induced acute and chronic pancreatitis models, we are now able to investigate the role of A3A in the inflammation, in AD inflammation, in tumor regeneration, and tissue damage. So using our acute pancreatitis models, we found that wild-type A3A, but not mutant A3A, leads to a significant increase in the severity of acute pancreatitis in our cerulean-induced models. And this was seen by an increase in edema and lipase peaking both at 8 hours. And we also saw an increase in the pancreatic weight in necrosis and in apoptosis when wild-type A3A was expressed. In line with that, we found when wild-type A3A is expressed in cells in acute pancreatitis, they frequently undergo ADM formation, as seen by a co-expression or switch from amylase to cytokeratin 19 expression in those asthma cells. And this was found in a morphological level, but also on transcriptomic level. So we also wanted to investigate whether A3A increases the inflammatory response during acute pancreatitis, and we looked for CD45 infiltrating immune cells and found that with wild-type A3A expression, there's a significant increase at 8 hours, 24 hours, and day 0 after 2 cerulean injections when wild-type A3A is present. However, when mutant A3A was expressed, only a slight increase was observed. Interestingly, the most upregulated pathways were inflammatory pathways like in NF-kappa B, JAK-STAT, and interferon inflammatory signaling pathways in what we saw in qPCR and in RNA-seq. By virtually dissecting the immune cell subtypes and also perform multiplex staining, we found that there is a significant increase of CD8 T cells, of macrophages, of NK cells, and then very prominent B cell infiltration. And this was mirrored by an enrichment of gene sets associated with those immune cell subtypes, and also in our multiplex staining in those slides. So both the severity and the immune response were most prominent when the deaminase function of A3A was present and only slightly affected by the deaminase deficient form of A3A. This led us conclude that the deaminase function might be the driving source for the severity and immune response in our A3A chronic and acute pancreatitis models. So focusing on the deaminase function, we performed whole exome sequencing, and we didn't see a difference in the number of mutations on the DNA level. However, we found a strong signature for genes involved in recognizing foreign RNAs and RNA editing in our RNA-seq data. So this suggests that RNA editing might be an important underlying mechanism for the observed phenotype. And now we are investigating this using our RNA editing pipeline. And we have first preliminary data showing that the RNA editing goes up during the different time points of acute pancreatitis. And we see also an increase in the C2T. I haven't included those data because they haven't been properly analyzed yet, but we are on that. I also have shown you before that A3A is increased during chronic pancreatitis, and so we hypothesized that it might also play an important role in chronic pancreatitis, enhancing the severity and immune response during this disease. And so to investigate this, we analyzed almost 60 chronic pancreatitis patient samples by DNA sequencing and multiplex imaging. And segregating our patient cohort based on A3A expression, we found that A3A significantly correlates with an increased fibrosis, and we also an increase in ADM formation. And we found more frequently Panen lesions when A3A was highly expressed in those samples. To investigate whether A3A also plays a role or affects the immune response in chronic pancreatitis, we performed multiplex staining and found that high A3A expression correlates with an increase of CD68 monocyte macrophages and a decreased infiltration of CD8 T cells. And we are also like looking more deep into this right now. But most importantly, we were interested whether A3A can enhance the inflammatory triggered mutagenesis in chronic pancreatitis and can basically enhance the likelihood to develop pancreatic cancer. And for that, we performed targeted DNA sequencing and found that A3A and it didn't correlate with the overall number of mutations. However, we found a significant increase in the number of APOPEC-specific mutations with functional consequences like C2T, C2G mutations, nonsense, missense, and exon mutations in oncogenes and tumor suppressor genes like CDKN2A, P53, HRAS, ALK, suggesting that APOPEC3A might enhance the inflammatory triggered mutagenesis. And right now we're investigating this in our in vivo models with because this was a targeted approach, so with a like whole exome sequencing. So to summarize our findings, A3A aggravates the severity and inflammatory response during acute pancreatitis in a mostly telomerase-dependent manner. We find RNA editing as a potential underlying mechanism we are exploring right now, and A3A correlates with fibrosis, immune response, and the severity of chronic pancreatitis, and might facilitate inflammation triggered mutagenesis in this pre-oncogenic setting. So with that, I will end. I want to thank my team at the Ahmed Center for Pancreatic Cancer Research and the Anderson Cancer Center, all of our collaborators, and our funding sources, specifically the APA Foundation, who funded this project initially. Thank you.
Thank you. I would like to take only one question.
Hi, very interesting talk. I was wondering, do you have any insights into RNA editing in what cell type do you think is important? You mentioned macrophages and T cells a lot. Do you think that this is about an antigen presenting cell, or what lineage is it operative in?
Yeah, that's a very good question. So it has been shown that A3A plays a role in RNA editing, like in monocytes macrophages. In our model, A3A is only expressed like in the epithelial cells, but you're right. So when we do the RNA-seq, we cannot basically distinguish where the RNA editing is coming from, if it's come from the immune cells or from the epithelial cells. In that case, yeah.
Do you have any thoughts?
Not yet. We're kind of like trying to investigate that now.
Very interesting talk, but I missed the purpose of the study. You are using pancreatitis as a model system to study your enzyme, or you think this is a mechanism in general in pancreatitis?
Yeah, so we know that A3A and the enzyme A3A is upregulating during inflammation. So it's we saw that it's upregulated during chronic pancreatitis and also during other inflammatory diseases. So we wanted to see if we upregulate A3A, does it have an effect on the severity of acute pancreatitis? And this could be something which could be potentially be targeted in the future to reduce the severity of the disease.
Thank you. Thank you all for joining this session. Next session will start shortly.